Hi, everybody. Welcome to the FORTE Coordinator webinar. We are so excited to have everyone here today. My name is Kristen Kotsko, and I am the Director of the Clinical Coordinating Department at Energy Oncology in Pittsburgh. My coordinating department hat, we answer clinical questions for breast and colorectal cancer treatment trials that come out of the Pittsburgh office, and we also answer questions for FORTE. My FORTE hat, I work with Cheryl Leal, Rocky Schoen, and Jeff Duker on the FORTE trial. They've been with the trial since its inception, long time. Cheryl, 3 years, right? I think it's 3 years you've been with us. 4 years. Oh my gosh, time flies. Wow. Cheryl's been with us 4 years, so almost since trial inception. We are super excited that we hit 50%. 4,750 patients were accrued. We're actually at 4,884 as of about 10 minutes ago, which is 51% of the total accrual, and we couldn't hit this milestone without all of you. Can I see a show of your virtual hand if you have put a patient on the FORTE trial? So about half of the people in attendance have put someone on FORTE. That's exciting. Once we get started with the presentations, I'm going to ask if you have any questions or comments, please feel free to type them in the chat. At the end of the meeting, there will be a Q&A panel. So if you have questions you want to ask, we can take you off mute. You can ask them then. But for now, we're going to just have you put them in the chat. We are going to start the coordinators the coordinator meeting with screening for FORTE Polyp 101, and Sarah from Kaiser is going to kick us off. Sarah, are you ready?
I am. Let me share my screen here.
Go right ahead. And I'm going to let everybody introduce themselves if they want to introduce where they're from and that sort of thing.
Great. So my name is Sarah Simmons, and I'm with Kaiser Permanente, Southern California. And I'll be presenting the Polyp 101 portion of today's webinar. Today we'll be covering colonoscopy and pathology reports. We'll also be going over the FORTE eligibility criteria, and I'll point you towards some helpful resources. So what happens during a colonoscopy? The physician's aims are to find and remove all polyps, describe their size and features, identify how they were removed, and then send those polyps to pathology for further identification. When reviewing colonoscopy reports, you might encounter some terminology you're unfamiliar with if you've not been on the FORTE study very long. One of those is the word sessile. That just means that a polyp appears to be flat, but it doesn't identify what type of polyp it is, so it's not super important to the FORTE eligibility. Another term is hyperplastic. These polyps are generally pretty low risk, and whenever you see the word hyperplastic in a colonoscopy report, that's the endoscopist's best guess. The polyp type is ultimately determined by pathology. The final term we have here is pedunculated. That just means that the polyp is on a stalk, similar to the photo on the right. These polyps are often too large to be considered eligible for the FORTE study. An important note is that polyp size is determined from the colonoscopy report, not the pathology report. One reason for this is that the tool used to remove polyps can help physicians estimate the size of the polyp, as you can see here on the right. In colonoscopy reports, you might see the term small or diminutive, and as a rule of thumb, that means that the polyps are less than 10 millimeters in size. There are a few different removal methods that you might come across in a colonoscopy report. Here you can see some images from a forceps removal. In A and B, you can see the forceps opening and closing around the polyp, and then the forceps are pulled towards the scope with the polyp tissue remaining in the forceps. Another removal method is the cold snare, which is also opened and closed around the polyp. In image D, you can see a red circle, and that's the polyp that was removed. But you can also see a ring of lighter tissue around the polyp, and that was actually healthy tissue that was removed to ensure a clear margin of the polyp. So going back to taking measurements from the colonoscopy report and not the pathology report, pathology might measure the entirety of the sample we see in photo D, and that would give an overestimate of the size of the polyp. On the other side, a polyp could fall apart into fragments during removal, and pathology might measure those as separate samples, which would give an underestimate of the size. Once the polyps are removed and described, they're put into jars. It's helpful to note that there's not one uniform way of jarring these polyps. I find it useful to cross-reference the colonoscopy and pathology reports to keep straight how many polyps are in each jar and which results apply to which samples. The bottom line here is that pathology reports are where we get information on polyp type, and the colonoscopy report is where we get information on polyp size and the number of polyps. Now that we have an idea of how pathology and colonoscopy reports can be read, we'll move on to FORTE eligibility criteria. Eligible patients must not have had a history of prior adenoma. So if they've had a prior normal colonoscopy, they'd be eligible, or prior colonoscopy with only hyperplastic polyps, that would also be okay, since those are fairly low risk. What if the patient has had a colonoscopy before, but they don't have the documentation on file for that colonoscopy? We always want to try our best to get a copy of those past results, but that might not always be feasible for some reason or another. If the patient knows that they were told it was normal, or specifically that there were no adenomas, that patient would be eligible. If they're not sure what the results were, but they were told to come back in 10 years, they're probably also eligible since that's consistent with a colonoscopy with no adenomas. If they remember that they were told that there were polyps, but they were benign, the patient would be ineligible if we're unable to produce the past report, since by definition, the adenomas are benign polyps. Another requirement is that polyps must have been completely removed during the colonoscopy. You may see fragments mentioned in the pathology report, and that's okay as long as the colonoscopy report specifically mentions that the polyps were completely removed. Every once in a while, you might encounter a situation where a polyp is mentioned in the colonoscopy report, but not in the pathology report, or the pathology report might say no polyp tissue found. This is likely because the polyp was lost between removal and being placed in a jar for pathology. Keeping that in mind, and that patients must have 1 to 2 adenomas for enrollment. If we have only 1 polyp removed and no pathology, we'd have to consider that patient ineligible since they might not have had the 1 qualifying adenoma. If they had 2 polyps removed, we know 1 was an adenoma and we don't have pathology results for the other, we can consider them eligible because they had either 1 or 2 adenoma. If 3 polyps were removed, we know there were 2 adenomas, and the 3rd polyp we have no pathology for, we'd have to assume they're ineligible because they might have had 3 adenoma, which would make them ineligible for the study. Here are some less common polyp pathologies. One is traditional serrated adenomas. These patients are excluded from the study, but we have to specifically look for the word traditional here since sessile serrated adenomas are still eligible. Tubulovillous adenomas and high-grade dysplasia are also excluded from the study. If you see hyperplastic or serrated polyp with adenoma features, that can be read as an adenoma. And if you see the term lymphoid aggregate, that's not an adenoma and not really of concern for this study. Patients in this study must be 45 to 70 at the time of their qualifying colonoscopy. It's okay though if the future planned colonoscopies fall beyond the age of 70. For example, if someone's 65 and they're put in the 10-year group, they would be 75 at their follow-up colonoscopy, and that's okay. Patients are ineligible if their life expectancy is less than 10 years at the time of the qualifying colonoscopy exam. That can be left up to the determination of your local PI. Some similar terms that are easy to mix up, in my opinion, are IBS, or irritable bowel syndrome, and IBD, inflammatory bowel disease. IBS patients are eligible, but IBD patients are not. And I wanted to give a special thanks to Dr. Duker because I reused a lot of these slides and photos from one of his presentations about a year ago. And if you've got any questions that I didn't answer, you can either put them in the chat or here's a helpful email you can use as well. So thank you to everybody.
Thank you for calling out the Forte email address. I appreciate that. So the Forte email address is a dedicated Forte email address that there's myself, Cheryl, and two other nurses in the CCD have access to. So thank you for calling that out. Excellent presentation. You did Dr. Duker proud. He would have been proud to hear you do that and use his slides. So now I'm going to turn the presentation over to Cheryl Liao, who everybody on here knows. Cheryl is, we call her the face of Forte. So we're going to let Cheryl talk to us about some resources for new staff joining Forte.
Thank you, Kristen. And yes, thank you, Sophia. That was absolutely fantastic. That was a great recap of Dr. Duca's presentation. If you do want more detail on that, I guess this is the first resource I'll be sharing about Forte. We have the Forte YouTube channel, which is quite easy to find. If you just look on YouTube and look up Forte Study, you'd be able to find it. And we do have the recording of Polyp 101 on there. So Sophia did a great recap, but if you want more detail or a more robust discussion about that, yeah, you're able to review Dr. Duca's presentation at any time. So yeah, today I'm going to be talking a little bit, quite briefly, about the resources for new staff. This is because, as we all know, clinical research has some turnover. We have tragically lost many coordinators to medical school, anesthesiology school. We're very excited for you, but it is a tragedy for us. But we're always excited to have new people working on Forte with us. But of course, for those of us who have been here a while, it's always helpful to have a refresher on how to access everything related to Forte for anyone who's new. And so, first things first, I did want to share this chart. It looks quite overwhelming on first glance, I think. But this chart can be found on the Forte resource portal, which is on the NRG website. The Forte resource portal, long story short, is a way for us to organize the materials that can be found on CTSU. As many of you are aware, CTSU is run by the NCI, and it's a little bit difficult to navigate if you're not familiar with it. And since we have a lot of people who work on Forte who don't necessarily use CTSU frequently, we just wanted a different avenue to be able to find resources. And so if you're having someone new work on Forte, one of the frequent early questions is, how do I get access to all of the systems that are needed? Because there's quite a few, there's different kit ordering sites. There's, of course, Rave, Open to randomize patients and enter data, Vision Tree, etc. And so we made a chart that gives you a brief review about how to access each of these sites. So if you're ever looking for a URL, anything like that, hop onto the Forte resource portal. You'll use your login for CTSU to access that, and you'll be able to quickly find the resources you're looking for. And additionally, there's also some resources, but also some contact information on the resource portal if you have any questions specifically, regarding Vision Tree or anything. But as Kristen said earlier, if you're not sure where to go, feel free to reach out to Forte email address. We're happy to help. I did want to quickly review remote consent as well. This is just something that has been coming up more frequently over the years with Forte. And this is just because we have had permission from NCI to enroll patients remotely to Forte. This is because Energy CC 005 does not require an in-person visit to enroll. There are many sites that are preferring an in-person visit just so that you can get everything done at one go. But again, that is not a requirement. We also have very many successful sites who are doing remote consent. Um, some enrollment methods for remote consent include using RedCap, DocuSign, using snail mail. We really encourage you to use and explore whatever works best for your site. We don't have any requirements from Energy regarding how to enroll a patient remotely. From once a patient is randomized, you can either use snail mail or email or phone to complete the pro questionnaires, or you can also use Vision Tree. Vision Tree holds monthly training sessions through NRG regarding how to use that portal. And you're able to work with your patient to get them signed up for Vision Tree, which is very simple. And you're able to push the information to them, and once they've completed their pro questionnaires, the information is pushed directly into Rave, so you don't even have to touch anything related to that. Regarding the stool and blood collection, we have the Omnigene Gut Kit, which is sent by mail typically, or if your patient happens to be coming to your hospital, you can give it to them then. And the patient then completes everything in the comfort of their own home and mails it off on their own. That being said, we do have a few sites that are working with their patients to bring the kit back to them for mailing. This is just because some patients are more comfortable having someone go over the kit and make sure that they did everything right before they mail it off. So again, all of this is up to the discretion of your own site and what you think your patients would be most comfortable with to complete their sample collection. With the blood sample collection, I will be going over Travel Lab a little bit more in detail later on, but I did want to mention, of course, we are working with Travel Lab, which is a mobile phlebotomy service who is able to work on Forte to get blood draws completed at a vast majority of our sites. So if you're interested, go ahead and sign up for that. Follow-up can be done in a variety of ways. Once your patient has been randomized, we have an annual follow-up system. And stools are collected at 24 and 48 months from randomization, as well as past the first year. And so again, those are all can be done remotely. We do encourage you to contact your participant directly. Part of the reason for that is we do really want to make sure that the participants, because this is a long study, are reminded that they have their colonoscopy date coming up sooner and sooner as the years go on. So the follow-up is one good way that you can remind them and let them know, hey, your expected colonoscopy date is X date, make sure to keep that in mind. And then of course, as you get closer and closer, work with them and make sure that they are scheduling that appointment. So follow-up can be done through phone call, email, different ways of contacting the participant. But of course, if you have a participant that says, hey, I'm too busy, I don't have time for this or anything like that, or I'm not interested in having that discussion, you can definitely complete this via email EMR review. And we do want to mention that participant being busy is not typically a reason for them to withdraw. Um, uh, we are able to follow them via the EMR, so making sure that participants are aware that you don't have to be contacting them as long as they are comfortable with with the EMR review, they can stay on study. And as I mentioned here on the slide, many of our high accruing sites have remote components, and we have heard much about positive experiences with this. So on that note, can I see a show of hands on who is doing some sort of remote consent, and maybe in the chat pop in what kind of methods you're using? Are you using DocuSign or RedCap, anything like that? It's always great to hear. Fantastic. Yes, many sites. I see like maybe a third of you on here, maybe more, are doing some sort of remote consent. So that's absolutely fantastic. Well, and we did have a presentation at the energy meeting on the Forte workshop from Lisa Beaverson with the biobank. And I did want to also quickly recap a few of her highlights just to share it with a wider audience. And regarding stool collection, she does, Lisa's very aware of the common pitfalls that we experience with NRGC C005. And so I did want to quickly share a couple of things. One is, as much as possible, please remind your participant to label their stool collection with the collection date. And of course, make sure to put the participant and site identifiers on the tube and accompanying documentation before distributing it to your participant. This is primarily so that we can identify and make sure that your site gets credit for the completion of the stool collection. This is because, and a very key thing, the shipping label does not actually contain any return address information. And so when if we're missing any sort of identifiers, the only thing we have to go off of is the city of origin from FedEx. And so we do play a little bit of detective work on our end to try to figure out, at the very least, what state this came from. But at that point, we're going to have to reach out. I'm sure you guys have seen the occasional email from me saying, "Hey, can someone claim this claim this kit?" So as much as possible, do make sure that your participant is labeling the collection date, but also make sure that the participant identifiers are on all the documentation ahead of time. The other thing that is occasionally missing is the transmittal form. So make sure that that is being filled out prior to the kit being mailed. Recently, we have had a couple of new hiccups. For those of you who have been around for a while, we have been through many iterations of trying to make sure that participants are aware of how to complete their stool collection appropriately. But recently, we have had a couple of issues where the collection tubes were not fully closed. We've had much better success regarding the amount of stool being put in the tubes, and also people not disposing the reagent prior to collecting their stool. People have gotten much better at that, so we're grateful to you for working with your participants for that. But yeah, we want to make sure that thing is sealed tight because it does affect the quality of the sample if there is leakage. And then there was a strange instance of the participant putting the stool in the blood collection tube. This must have been someone who was doing a remote method for both. And so, just working with your participants to clearly label and identify each of those kits and make sure that they're using the right kits. Occasionally, the shipment is going to the wrong location because we have the biobank that works on the blood collection, and then, of course, the stool collection biobank. But again, that does not seem to be as much of an issue. It does just delay some information being collected and, of course, your site being credited for it. So that is some of the information that I wanted to share from Lisa Baberson as well. I think we're going to hold questions till the end, but if you have any questions in the chat, I'm more than happy to help as well. And I see here, we see a few sites. Yeah, it looks like it's pretty split between DocuSign and RedCap regarding remote consent. And something called Florence e-consent. That is a new one for me. So we'll definitely have to hear more about that from KP Colorado. But thank you so much for your time. I'm going to stop sharing my screen and turn this over to Sophia for a recap of the best practices for the FORTE introductory call.
I'll just give a quick overview on some best practices. These will be specific mostly to my site and just the processes that work for us. I am a VA, so we have additional hoops to jump through. So on that note, let's get started. Here we go. So initiating contact, our procedure here at this VA is to mail a letter before we do our initial phone call, just because we're not actually permitted to do that cold calling. But this actually provides a pretty good advantage for us, given that most people that we call already have an idea of what we're going to be talking about. And there are approved recruitment letter templates available on CTSU. You can put in your own contact information, any information specific to your site, but the approved language is already there, which is super helpful. Our letter, in addition to having our site contact information, also has a time frame for when they can expect a call. This sort of opens the door to contact and sets realistic expectations. I've included an example here for the language that we use. We say, we will contact you by phone if we have not heard from you within 2 weeks. So this is counted as our first attempt at contact. That letter is our first attempt, and we stick to 3. So after that letter, if we haven't been, if we don't receive a call from the potential participant, we will make a phone call. If they don't pick up, obviously we leave a voicemail with a callback number, and second phone call would then be our third attempt. If all 3 attempts lead to no response, that's considered unable to contact. One thing I'll mention, which we'll get into in a little bit about leaving a voicemail, is make sure to add a note that it's not urgent, as we need to be HIPAA compliant in these voicemails. You can't give too much information, so I always like to add a note of saying, calling from a VA, nothing urgent, just so that they don't think that anything is, crucial about their clinical care. Okay. So, and on to preparing for this phone call. A really good practice is to make sure you have all your ducks in a row before you even dial the phone. I like to have a pre-written script, or there's 2 other materials that are equally helpful. A copy of the consent form is good to have on hand as a quick reference. It will outline study expectations and study design. Or the recruitment letter. It tends to be a pretty good overview. It's designed that way on purpose, so it's a helpful material to have available if you don't want to have a pre-written script. So make sure you have those materials open, either printed out or open in a window on your computer. I'd be prepared to also explain the 4 major W's, as I've written here, or the key points you want to highlight. You want to introduce who you are, for sure introduce where you're calling from, the reason why they're receiving a call, and then what the study's about. 2 other things to keep in mind. It's easy to think that you're prepared for the phone call, but you're not prepared for everything that's going to happen. One of the things that could happen is if they don't pick up, you'll have to be prepared to leave a voicemail. This is a very simple thing, but could be easy to forget. You'll want to leave a HIPAA compliant voicemail. Really basic, you'll just say your name. I say, this is Sophia, I'm calling from a VA. Again, nothing urgent, but when you get the chance, please give me a call back at my number, my extension. Another thing easy to forget is be ready if they say yes. We're all hoping that they say yes, but we want to be prepared if they are. So be ready to schedule that first appointment. It's helpful to have your calendar open and maybe the patient's electronic medical record to coordinate a visit. It's always best to coordinate a time when they're already here so that they won't have to worry about travel. So if you know, if you're able to see their upcoming appointments at your institution, that's a helpful resource to have open. Now into the phone call, I've just included an example script on this slide. The phone call, it's up to you exactly what you want to say. You can have a script. You can sort of, if you're someone that's better at winging it, again, you can have that consent form open, that recruitment letter open for reference just to keep you on track. But this is the general formula that I follow. I will first confirm who I'm speaking with. You want to make sure that you're speaking with the potential participant themselves. So I will say, hello, is this Mr. or Miss so-and-so? And if the answer is yes, you can continue. If the answer is no, you would request to speak with that person if they're available. Next is to introduce yourself right away and where you're calling from. And then if you have the opportunity to send that recruitment letter in the mail, it's always a good place to start. It's a good jumping off point to see if they've received that letter. I'm calling regarding a letter we sent you in the mail. It's about an opportunity to take part in a research study and then check in, see if they received or read the letter. In my experience, most people have not read the letter, but that's completely fine. So I've put 2 options here. If they say no, no problem. I can tell you what it's about if you have some time right now. Yes, awesome, but we'll have to talk a little bit more. So great, do you have a few minutes to talk some more about the study? From there, it's pretty much the same whether or not they've received the letter. I would lead with the study doctor. I find this to be a successful point because it establishes a little bit of street cred. They might not know who you are, but the doctor goes a long way to sort of make them rest assured that this is approved research. This is a medical professional who has identified them as a potential good fit for the study. So I will say Dr. So-and-so, whoever your PI is, give a little blurb of who they are. I would say a GI doctor here at the Providence VA. Thought you might be a good fit for the study based on your latest colonoscopy. And then get a little bit into the purpose of the study. This can keep it brief, but you want to be informative. The purpose of this research study is to find out the best timing for repeat colonoscopy for people who have had polyps removed during their procedure. If you choose to take part, set expectations of what the study will involve. You'll be randomly assigned to have a repeat colonoscopy in 10 years or 5 in 10 years. I also like to give them an idea of the procedures they'll have to complete in addition to the 2 study groups they may be assigned to. So I emphasize that it involves just one in-person visit, but also the annual follow-up. So you'll be asked to complete questionnaires, provide small stool samples and a single blood tube for research, and be contacted at least once a year by phone, mail, or email to get updated information about your health, results of colonoscopy exams, or other medical information. After that, it's time to check in with the potential participant, gauge interest, see if they have any questions, and then if they'd be interested in scheduling a visit. Lastly, I have some tips, just general things to keep in mind. Use a warm and friendly tone. A trick that I've heard is to smile while you talk, even if you're not visible to them. It makes a difference in your tone. Also, make sure to use clear and simple language. You want to obviously avoid complex medical language and stick to layman's terms. A prime example of this is to use the term polyps instead of non-advanced adenomas. Also important to practice active listening. You have your pre-written script ready, but there's also someone else, there's another human on the line with you who has their own concerns, questions, and be sure to listen to those. Be sure to verbally acknowledge and thoughtfully respond to their questions and concerns, and also know it's always okay to not know the answer. It is better to say, I don't know, but I will find an answer for you, than to try to create some answer without being 100% certain. Lastly, you want to avoid applying pressure and emphasize that research participation is always completely voluntary, and allow them enough time to make an informed decision. And that's all I've got.
Thanks, Sophia. That was absolutely fantastic. I love to hear the different recaps that we get from the different sites about for the FORTE introductory call. We've learned so much from each of you. And now I'm going to turn it over to Isabella. Isabella is the data manager, the FORTE data manager with NRG Oncology, and she's going to talk a little bit about consent withdrawals.
My name is Isabella Frack, as Cheryl said, and I am the data manager for this study, and I am the data management supervisor in the Pittsburgh office. Next slide, please. Thank you. The location of the form, the consent withdrawal form in RAVE, the database used for the data collection, is shown on this slide. The form can be added by using the add event function, and this is pointed by the green arrow. Forms due on or before the consent withdrawal date are expected to be completed. Forms with due dates after the consent withdrawal date should not be completed, as they will be inactivated by the data manager. And on this slide, there's a 48-month tool questionnaire and 48-month tool. And as you can see, those are due in 2027. So those would not be expected to be completed. So they should not be answered as no. They should just stay blank, because if the form is touched by the site, we have to query and we have to confirm that we may inactivate the form. Some sites contact data management after the form has been added. The form is reviewed. If the participant wishes are unclear, queries are issued to obtain clarification. If it's clear that the participant wishes to withdraw consent, the request is approved. So you may see like a kind of repetition of the same query, but we want to make sure that's correct, that the form wasn't just added too early. Next slides, please. Thank you. A document addressing consent withdrawals developed by CCD and data management is posted on the CTSU website. Participants are not to be withdrawn from the trial for the following reasons. Unable to contact the participant doesn't answer the call or doesn't call back. The participant has moved. The participant is unwilling to comply with follow-up contact. The participant is unwilling to comply with randomized assignment of 5 and or 10 years. After randomization, there is a clinical reason for the participant to not follow the randomized assignment of 5 and or 10 years. Next slide, please. Follow-up period is calculated from the date of randomization. Participants' follow-up is every 12 months, and this is listed in Table 1 of the protocol. First follow-up will be due a year from randomization. Follow-up expectancy is dynamic and based on last submitted follow-up form. If the participant was randomized in January 2024, follow-up 1 will be expected in January 2025. However, if the follow-up entered date is February 2024, and this refers to date of last contact reported in RAVE, next follow-up will be expected in February 2025. Next slide, please. Site staff should attempt to contact participants annually from randomization to obtain disease and vital status, unscheduled colonoscopy information, diagnosis of a new colorectal cancer or other malignancy, additional health information. If a participant cannot be contacted, as I mentioned before, because doesn't answer the phone or does not return calls, doesn't respond to emails, the participant's electronic medical record may be used to obtain the annual disease and vital status information. And this is something that's mentioned in the protocol. And sometimes whenever we issue a query on a consent withdrawal form, we use exactly the language from the protocol, asking that if electronic medical records can be viewed. And that's all what I have. Thank you. And thank you, Cheryl.
Absolutely. Thank you for the review. This is very helpful information. We're going to review the 5-year colonoscopy challenges and best practices now. Laura Amsden with Kaiser Permanente Northern California is going to present. I see you're ready to go. Thanks, Laura.
All right. Can you hear me?
Yes, loud and clear.
Okay. Okay. I should be in presenter mode now.
Perfect.
Great. Well, I'm Laura Amsden from the FORTE study site at KPNC. And as Cheryl said, I'll be discussing the challenges and best practices relating to completing the 5-year colonoscopy. And these challenges tend to fall into 3 main areas for us. Participant, the Kaiser Permanente system. Now, of course, I'll be talking specifically about KP in Northern California, but I encourage each of you to think about your own systems as I talk about KP and think about potential challenges and best practices that might come up for you. And then also for the last bucket would be people that have moved out of our KP system. So a major challenge is participant disengagement or lack of engagements. I'm sure we all encounter this. Some participants just do not respond to either study or provider outreach. While they may respond, just simply tell us, I don't want to do my 5-year colonoscopy. I'm just not going to do it. I'm overwhelmed or for whatever reason. Then also not reading messages. Kaiser Gastroenterology contacts patients when they are due for a colonoscopy, and they do this through a secure portal. So patients get an email from Kaiser saying, log into your secure portal, you have a message. And that's all they say. A big majority of these messages just go unread. And because of that, then our study staff have to then reach out to participants and talk to them about scheduling their 5-year colonoscopy. And then, of course, delayed scheduling. We work with participants to schedule their colonoscopy and work with them, and they finally do schedule it. But a couple of times it's happened where, oh my gosh, they schedule it the day after their window closes. And it's still a late colonoscopy, even if it's a day or two after the window closes. And then moving on to the Kaiser Permanente system, when we first started scheduling participants for colonoscopies when they were coming due, Kaiser had a big backlog due to the pandemic. Thankfully, that has dissipated quite a bit. But to start with, that was a huge issue and a huge challenge for us. We also have encountered updated screening guidelines for colonoscopies, and this creates certain challenges when providers do not see that a particular patient is in the study, and they reach out to them and say, good news, you don't need to come in 5 years, you can come in 7 or maybe even 10. And that means that we then have to reach out to the gastroenterologists and the particular person that reached out to the patient and talk to them about that, educate them, but then reach out to the participant and say something different than their provider has just told them and try to get them back on the schedule. And occasionally participants receive bills for colonoscopies that should be fully covered at Kaiser. And although we have successfully reversed all of these charges that we have been made aware of, these cause participants significant frustration. And then for participants that are no longer KP members, as they come up against their 5-year colonoscopy timeline, they oftentimes will get alternate follow-up recommendations from their new provider. They oftentimes can have different insurance coverages, which could limit a 5-year colonoscopy. And then, of course, difficulty obtaining medical records from outside providers. We have to be very, very persistent many times to get those medical records. Hey, and best practices. Some of these may seem obvious, but they are just a good practice is to definitely track the due date of the colonoscopy and the window date. There's a 1-year window in front and a 1-year window behind. So it's really a 2 years that participant has to complete their 5-year colonoscopy. And of course, early outreach and reminders. We do this by looking, we can tell when a person has a colonoscopy scheduled. And if it's not scheduled in a timely manner, we will then reach out to the participant both by phone and email. And then also coordinating our follow-up. We align colonoscopy reminders with other study activities such as stool kit outreach. We have a lot of participants who are coming up on their second stool kit, but they're also becoming due for their 5-year colonoscopy. So instead of 2 different outreach attempts, one for the stool kit and one for the colonoscopy, our tracking system reminds our study staff to combine those 2 messages to avoid multiple separate contacts. And of course, within any system, whether it's Kaiser Permanente or any other, provider education is critical. Both primary care providers and gastroenterologists, they need to recognize that their patients are enrolled in a clinical trial and understand the requirements for colonoscopy scheduling. We oftentimes will reach out directly to schedulers, and that's another great best practice. Not just reaching out and educating PCPs and GI, but also the exact schedulers themselves, whether they're MAs or RNs. And of course, being proactive in developing those relationships. Oftentimes they're relationships on a one-on-one basis because we're communicating within our medical record system about a particular patient. But many times these schedulers and RNs have more than one of our participants on their list to schedule. So being very proactive about that is a great best practice as well. And for non-KP members, of course, as soon as we find out that they're not a KP member, we advise them to let their new provider know that they're in the study, what their colonoscopy schedule is. We also will reach out if the participant wants us to, can reach out to the provider, talk to them about the provider either by email or by a phone call. And of course, as I said before, a challenge is obtaining medical records that are outside of our system and just persistence. And knowing that the first person you call may not be the person that's actually going to help you. Usually they are, but if something funky or weird has happened and they can't find the medical record, finding the person that can actually help you through persistence is a great best practice. And of course, tracking each participant, if they're a non-KP member, knowing who their current provider is, maintaining and staying on top of that so that we know that is super important. And here's a summary where I've taken a best practice area, addressed the challenge with it, and the recommended approach. So proactively tracking colonoscopy due dates, engaging participants appropriately, coordinating outreach efforts, educating providers, involving the broader care team, whoever that might be, and whoever makes sense in those 5-year colonoscopy schedules, and persistence in many areas, whether it's in obtaining those medical records or persistence in reaching participants in obtaining who any new provider might be. And also stepping back and looking at where you think those barriers that you might have might be, whether it's scheduling or people moving in and out of your system. Identifying those barrier earlier can help determine best solutions. And that's what I have. Thank you so much.
Thank you for sharing, Laura.
Of
It's very
course.
helpful to learn from the sites that have been doing Forte for a while, especially some of these challenges around follow-up colonoscopies, because this is something we will all be facing as time goes on. And yeah, as the Forte trial continues, remember that a lot of these best practices will also apply to the tenure arm, especially to the tenure arm with some of the ones that involve, participants falling off or moving hospital systems. A lot can happen in 10 years, so making sure that we're aware of these challenges and how to face them is very helpful. So thank you for that, Laura. Now I'm going to turn it over to Anna Rosenblatt from the Bay Pines VA to discuss pro questionnaires and sample collection.
So hi guys, I'm Anna. Like Cheryl said, I am the lead coordinator at the Bay Pines VA, and I'm glad I can spend some time with you guys talking about how to get the stool sample and the surveys collected. So, first off, I always start laying the groundwork for this on day one. I emphasize to the participant, we do have plenty of time to get this done, but we want to start planning for it now. I don't want us to kick the can down the road too far. I let them know, we want this to be convenient for you in terms of when we get it done, but the sooner the better, because the kit is small. I joke it's kind of like socks. It's easy to misplace. And also by, getting the wheels in motion for this early on, I feel like it kind of helps to keep the momentum of their participation going. I also encourage everyone to really take advantage of how adaptable the protocol really is. There are multiple ways with the stool sample that we can, accommodate the participant, what's going to be best for them, and what works best for you and your study team. For example, my site is fortunate enough to be able to offer in-person support with this in terms of shipping the sample for the patient. So I give my patients the option. They can drop off the sample with me and then I'll ship it on their behalf. But of course, there are patients who, for one reason or another, prefer not to have to come back on site. And then in that case, we arrange for them to self-ship. So I just tell them, whichever route is going to make this as simple as possible for you. Of course, it's important to spend time educating the patient on how to collect, and for patients who are shipping the sample themselves to go over how to correctly package it. And I encourage patients to give me a call if they need a refresher on any of this before they, collect and ship that sample. And finally, I think it's really beneficial to spend a little time explaining to the patient the value of collecting this sample and the impact that it can have for NCI research. Whenever I'm asking a patient to do something, I want them to understand why they're doing it in the first place. I think it's, motivational and insightful for them. So I just want to take a second to highlight how thoughtfully designed the protocol is. It really allows for a lot of flexibility with timing, and it provides multiple modalities to get things done for each assessment. There are a lot of sites who are conducting this trial, and all sites have their own unique circumstances. So this allows for study teams to decide, which combination of tactics is going to work best for them and for their patients. For example, we have a really generous window of when we can get this done. You have an entire 12 months from each time point. There is the ability for the patient to ship the sample themselves. And then I also just want to point out, I really appreciate the option for paper surveys. We have two ways that we can collect these surveys, whether it be the Vision Tree app or on paper. And I might have an unpopular opinion here, but I like to keep things old school and do paper surveys. There's pros and cons to each approach, obviously. But I feel like doing them on paper kind of mitigates any potential for technical difficulties. And then I joke with the patient, this is just one less password for each of us to have to remember. But of course, I know there are sites where the Vision Tree is way more convenient for them and their patients. So I think it's great that we have these options. Next, you definitely want to make sure to spend time educating the patient on how to use the kit, of course. So when I am going through the kit with the patient, I actually have an expired test that I kept so that I can, open up the tube, show them the yellow platform, show them all the pieces, and, we walk through step by step how to collect. I let the patient know it's okay if you need to collect this 1 to 2 days before it's going to be shipped. I joke with them, not everyone has the most predictable bowel schedule, and that's okay. It doesn't have to be the freshest sample. It is relatively stable, as long as you're keeping it at room temperature. Don't freeze it, don't refrigerate it, don't keep it in your hot car. And as long as it's shipped relatively soon after collection, that'll be fine. So this is an example of the little goodie bag that I give to my patients. It includes the kit. I give them a complimentary pair of gloves, my business card, and then a spare bio bag. This is an example of what I'm giving to a patient who is going to drop off the sample with me to ship on their behalf. I've seen patients pack samples incorrectly in ways I could have never imagined. And so what I prefer to do is to keep the shipper and the packaging materials. And my site has a million extra bio bags. So I just take from my little treasure trove and give them one to return the sample in. So I want to walk through a few different ways that we approach this at my site. But I want to start off just by acknowledging I know a lot of sites don't do these visits in person. So some of this might not apply to every site, but it at least gives a good example of how customizable the study is. So first off, we have our traditional baseline visit. So I do all my consents in person. So at a typical visit, what I would do is go through consent and then have the patient complete their surveys. We'll also collect the blood sample at that first visit. And then at the end of the visit, we will start talking about getting that stool sample collected, and we'll schedule a day for them to drop it off. So this is an example of when a patient wants me to ship it on their behalf. I have a lot of patients who come here for their healthcare anyway, which makes it convenient for both of us. So we just look at their schedule and we align it with whenever they'll be out here next. And in this scenario, the surveys are going to be done in office with me when they come to drop that sample off. Next, we have what I call a blood stool hybrid, or the specimen extravaganza. So this allows for a shorter consent visit. Sometimes the patient comes late or something comes up for them and they don't have as much time as they were expecting that day. Or sometimes things with your schedule change and you aren't going to have as much time for that visit as you had been planning. And so in this scenario, I will just do the consent and the surveys with the patient, and then we'll schedule another visit, sometime in the next year, for them to come back, and we will collect the blood sample. And then in this scenario, again, I'm going to ship the stool on their behalf. Whenever possible, I really do like to do this, to have them drop it off, as long as it's convenient for them, because I like that extra in-person encounter. I feel like it's a good opportunity for us to keep the patient engaged. It's good for retention. And then lastly, we of course have the method where the patient is going to ship the sample themselves. This accommodates patients who don't live nearby or who prefer less in-person visits. So in that case, when we're talking about it, I am going to still ask them, when do you plan to do this? It doesn't have to be a specific day, but, a month, a week. That way, it's not just kind of up in the air, like, here's the kid, just do it whenever you want, because I feel like it's easy for it to fall off their radar that way. They have lives outside of our study. So I still like to, kind of discuss, when do you plan to do this? I'll put something on my calendar so that I know to expect it. Sometimes I'll check the FedEx tracking label that's associated with their transmittal form, and also, this gives me a heads up. Sometimes I'll follow up with them, especially if it's pretty far out, and see if they need any help. And then I can expect, that I'll be receiving those paper surveys in the mail soon. And so for patients who are self-shipping their sample, obviously I walk through the kit like normal, but I definitely make sure to take extra time walking through packaging. I show them how the two different bags go together. I fill out everything that I can for them ahead of time. I fill out everything on the label except for the collection date. And then I also give them a separate return envelope to send the surveys back to my site. I try to hyper emphasize that these are going to two different places, so you don't want to put the surveys in the shipper. So last, I want to touch on the surveys. When it comes to these, again, I like to explain and emphasize like the value of doing this. That way patients understand the importance of their contributions and why these surveys are even relevant. And whenever I start any new study, I make sure to familiarize myself with the surveys. I'll actually take them myself as if I'm a participant, so that I can see potential questions or confusions that might come up. For example, our surveys use a lot of, if yes, if no, skip logic, which for some patients can be tricky. But when it comes to questions, it is really important to remain neutral. Obviously, you want to be helpful, but also we can't influence their responses. These are, of course, patient-reported outcomes. And so when a patient is asking me something like, well, what should I put for this? I say something along the lines of, respond with whatever feels the most accurate to you. And then lastly, before I hand the questionnaires over to them, I always remind them, you're in control of what you choose to share. These surveys are only used for research, and, none of these responses are being shared with your doctors. These are private. But regardless, if there are certain things that you would prefer to skip, that is totally fine. Well, I hope all this was insightful. I know every site, is unique in their own special ways. So customize all of this based on what fits you and the patient best. And here's my contact info. I'm always free to answer questions or offer support with brainstorming, how to do the study most efficiently at your site.
Thank you very much, Anna. Thank you for reviewing all of the different pieces involved with the different methods of collecting stool, even though your site has a specific method. That's really helpful to see differences together.
For sure.
And now I'm going to close it out by reviewing Travel Lab again. For those of you who have been around for a little bit, this is probably information you've heard before. But we're always happy to share because we found that mobile phlebotomy has been a very helpful tool in enrolling patients to Forte. And so just going to quickly review the concept of implementing mobile phlebotomy with remote consent to increase enrollment. As I reviewed earlier, remote consent is a fantastic way of enrolling patients to Forte. As you've heard from all of the other speakers, we've got a lot of flexibility in how to work with our patients to make sure that the process of enrolling is as smooth as possible for their schedule. As you've heard from everyone, it's really good to keep in mind that we are asking them to volunteer for a research study that they don't necessarily benefit from directly. And so, trying to make things easy and streamlined for them is something that we're very passionate about here at NRG. And so the process of working with Travel Lab is quite simple. You would go on CTSU. We have the Forte Travel Lab manual on CTSU to break down the process. It's really quite a simple process. We've been working with them for more than a year now and have done many blood draws at this point. You register for the for Travel Lab using the Travel Lab registration form. There's just a couple of questions on there. It's really mostly contact information, so we knew who to contact at your site and who to provide login information since PHI is disclosed with Travel Lab to collect the blood sample. That being said, no additional contracting or payment is required. The contract is held with NRG, so all you need to do is register. We get the information from you and we share it with Travel Lab. And they set up a site-specific portal to prevent any PHI disclosure between the sites and to us as well to make sure that all of that is private, but we're able to get the blood draws collected. The Travel Lab phlebotomist confirms the appointment once you have scheduled it. We do request that sites schedule the appointment at least with a placeholder. This is just, again, as Anna was saying earlier, another point of contact for you to remind the participant of their participation in the study. And if they haven't done their pros or they haven't completed their stool, you're able to say, hey, let's get your blood collection scheduled. But also, have you done all those pieces? Is there a time that I should be expecting the pro questionnaires completed? It's just another touch point for you to make sure all of the different pieces are completed. Once the appointment is scheduled, the phlebotomist will reach out to the participant, confirm it, and complete the draw and ship the specimen to the NRG Biobank directly. So your main responsibility is to schedule the appointment and get the kit to the participant. A lot of sites do that by mail. I do have to point out one thing. We have had conversations in Travel Lab, and the number one thing to remind your participant when you're scheduling the appointment is that it does not have to be at their home, but it does have to be in a private location. So, if they've got a private room in their office, that works out well. But we're not doing blood draws at Starbucks. And so, yeah, as of about a week ago, we had almost 1,400 appointments completed and across a vast majority of sites working on Forte. So we've had a really good process working with Travelab to get these blood draws completed. Here are some of the sites that have done completed appointments. We're really glad to see that there have not really been any challenges across the country on working with Travel Lab to get these initial blood specimens completed. Something to note is if you wanted to know exactly what the coverage looks like, Travellab does have a map on their website. So if you just go to travellab.com, there's a map on there that has some up-to-date information on the phlebotomists available to complete blood draws. Their coverage is pretty good, but if you are in a really remote location, that may be a little bit challenging. But if you have any questions, reach out to us and we can contact Travellab on your behalf as well. And then we have other sites that have registered to do Travellab, but not necessarily done a blood draw. I don't mind sharing this because it's not, you are more than welcome to sign up. We don't have any restrictions on that, even if you're not sure if your site will use it, because using Travellab is, of course, up to the patient's discretion. It is a great thing to offer, but if the patient says, oh, I have an appointment coming up in a month, I can just do it then of course, not every patient has to use a mobile phlebotomy just because your site has signed up for it. And that's really all I had in terms of reviewing mobile phlebotomy with you guys today. I did want to, again, congratulate everyone for your hard work on FORTE. We really appreciate all of your effort to getting us to this 50% accrual milestone. I can tell you, Kristen mentioned earlier that I've been working on FORTE for about 4 years, and I will never forget that my first day when I logged onto CTSU, we had 3 sites. I know who you are. Maybe you know who you are. And we had 42 participants on my first day at NRG Oncology. So we have come a very long way, and it is really thanks to all of your hard work. And we are so appreciative for everything you've done to support this important colorectal cancer prevention trial. And yeah, we want to open it up to questions, discussion, anything you guys want to share about FORTE, your experiences. This is really a time for you. I had one other thing I wanted to mention as well. The speakers, really want to thank all the speakers today. You guys are, some of the FORTE superstars. Kristen and I were saying in the background. Many of you have been working on FORTE for a long time, or even a short time, but you have much expertise to share. And so for anyone who is newer to FORTE, we do have a FORTE coordinator committee made up of many of the people on this call who, have been working on FORTE for a long time, have developed best practices, and have shared some of them with you today. But if you have any specific questions, especially little idiosyncrasies, I know, again, for the VAs, we always talk about it. There's just some VA idiosyncrasies that come up. The FORTE coordinator committee is here to help. So if you have any questions, reach out to forte@nrgoncology.org, and we will be more than happy to route you to the right place. If you want to talk to a coordinator about anything they talked about today, we're able to share that as well. So does anybody have any questions, comments? I'm gonna look over the
Type
chat
them
real
in the
quick.
chat, or we can take yourself off mute and ask. You have the experts on the call, so ask away.
We are a very casual team. At the FORTE workshop at the NRG meeting, we did make people dance. For those of you who were there,
Dr.
you saw
Bauman
it.
started that.
Yeah,
And then
I should
Dr.
say
Duker
we as an
carried it through
NRG.
for
It
us.
wasn't Kristen and I.
Oh gosh, no. And it wasn't Dr. Schoen either.
No. We had we were doing celebratory dances to celebrate the 50%.
Yes, we were.
So we're very excited
We were
about that.
celebrating your efforts. Matthew, do you want to take yourself off mute?
Hey everyone, really great presentation all around, both from the NRG staff and from the external people. So just wanted to congratulate everybody on a very engaging presentation. My question's a little random, but I'm with Kaiser Permanente, Colorado, and we've had like a pretty successful few months. We like hit a record, I think, of like 8 or 9 patients in a month in April, which is a big deal for our little institution. I am curious if there are any like peaks and valleys when it comes to participant enrollment. Are we at the mercy of seasonal, summer travel or winter breaks or anything? Just because I'm kind of feeling it right now.
August is typically slow in the clinical trial world, not just prevention, but across the board. And then I always say once the kids get back to school, it seems like recruitment and accruals pick back up until the holidays, and then it slows down a smidge then.
Mm-hmm.
And I would think it would be the other way, that it would be busier, especially for a prevention trial over the summer where like teachers and other professions are off during the summer. So you would think they'd be taking care of healthcare stuff then, but I've always been proven wrong.
Yeah, thank you. We've definitely noticed a dip in July, and we haven't made any changes or anything, but it's good information to have. Thank you.
It peaks and wanes.
I think trial-wide we do see a bit of a slowdown. It's nothing too dramatic in the summer, and then of course, I mean, November, December are just a wash for I think everything.
Mm-hmm.
But I think I think overall it does tend to yes, enrollment tends to follow a bit of a schedule across the trials. But yeah, we totally understand that you can't control what your patients are going to do. And I see one of our sites have said very slow around in November and December months as well. Um, I see a question from, does anybody have anything else to chime in about enrollment irregularities or anything you've experienced? I'll give you a minute to type if you're deciding to type rather than unmute. I see Sophia had a question. How are sites handling distributing kits for the 24 and 48-month stool collections? Um,
My
Anybody have any
thought is they're
thoughts?
probably mailing them to patients, but let's see if the coordinators on the call agree with that.
Hey, I can speak on how we do things here at Bay Pines. Of course, in line with the way I approach most things, I try to give them out in person. Because we have such a wide window of time, usually during the year one call, I start, mentioning to the patient, hey, at year two, we're going to collect another sample. So maybe next time you're here at our facility, we can, give you the kit. And then the following time that you're here, you could bring it back to me. Um, or ship it out on your own, whatever's going to work best. But I am curious what sites who don't do in person are doing. And not that any of us like to, you know, think about the B word, budgeting and whatnot, but
Yeah.
do you just pay the cost of shipping the kit like out of your own funds? Because I know there's not really like a reimbursable cost to NRG for that.
I'm gonna chime in I know this is my own question, but
That's
for more
okay.
context, I'm asking the question because we've actually done both. I was
Mhm.
wondering what people's experiences were so we could sort of pick best practices. Um, I I will meet people, I'll leave it up to the participant, and we have shipped in the past. When I ship the kit and the questionnaires to the participant, we I'm not sure how billing works within our budgeting process. That I can't super clearly speak on, but I know that I think we charge it to the study, the cost of that shipping label.
Are you talking about the shipping label for the specimen to actually go to the
No.
lab?
No, the shipping label to go to the participant.
I think that would come out of your per patient dollars
Mhm.
or per participant dollars, I use. Yeah.
Okay.
So I see Matthew said that they mostly ship out via FedEx at Kaiser, Colorado. However is bolded, they do love when someone says yes to in person because it will have less issues. So yes, I think from what we've learned across the sites, we do see that it's almost like if the participants started out remote, they may be more comfortable doing things remotely. But if you started out in person, it's something that they're familiar with. It almost seems like participant comfort, aligns with what they started out with. Because Jody with the Metro Minnesota NCorp says that they inform them that a follow-up email or call, with a follow-up email or call, that the kit will be mailed to them. And that's because everything at Metro Minnesota NCorp is done remotely. So I think, understanding your participants and your site comfort level is really helpful here. I do see everyone also agreeing with Matt about in-person visits being a big win. Other comments on the kits for these dual collections? I see another question regarding the biobank. I was wondering if you have any insights into delays we are seeing with biobank specimens populating as overdue in RAVE. It seems that some samples we've sent aren't being updated until months later. Are there any known issues that might be contributing to this delay?
Isabel, are you aware of anything?
Yeah, I can answer the question. There are no issues in RAVE or with the biobank. The way it works, we just get reports from the biobank on a monthly basis. And I think we get them like in the beginning of the month. And after receiving those, we pushed the data into RAVE. So that's why you may be seeing like a month delay. And it depends when the sample was shipped to the biobank. So if it was like close to the end of the month, it may take 2 months. So I think all this depends. And overdue. Overdue is showing on collected and I think received fields or shipped. And this is only visible in RAVE and it's not affecting your performance report. Does this help? You're welcome.
I think the only thing I would add is that, the occasional delay could be because the participant, missed something on their collection form, or, just little things that would delay the identification of the participant, or, making sure that their transmittal form was completed correctly. If anything like that comes up, feel free to reach out. We're happy to connect you with the biobank to work through those challenges as well. I know that occasionally we just have samples that go to the wrong biobank entirely, and that would definitely cause a delay.
I agree with what just Cheryl said. If you have any question, just reach out. But I would wait like a month or 2 months and then I would reach out.
Other questions about FORTE? Give it another few minutes. Kristen, I think we always take it as a win when the questions are few. It
Oh, yeah.
means that people know what they're
Always.
doing with FORTE. And so if you have any other questions, feel free to reach out to forte@energyoncology.org. We're more than happy to help at any time. But in this case, I think we are more than happy to start wrapping things up.
Give everybody
Kristen, do you
some
wanna-
time back.
Valuable.
Yes, very. Yes, especially on a Monday.
Kristen, do
Thank
you want
you.
to last comments?
Yes. Thank you, everybody, for taking the time to hop on the FORTE workshop with us. We really appreciate your time, your efforts with FORTE. You're making it a success, and we really, really appreciate that. Don't hesitate to reach out with questions. We are here to help you be successful with the study. So please reach out. We are all very user-friendly, we'll say. It's a good, that's how I say it. And for anybody that's ever been on a call with me, I always say, I don't keep people on webinars just for us all to listen to each other breathe. So go have a good rest of your Monday, and we will talk soon. Thank you again for your efforts. Bye, everybody.
Thank you.
Thank you.
Thanks, everyone. Take care.